I'd like to introduce everybody to today's speaker, Kimberly Moore. She is the Director of Healthcare Revenue Cycle Consulting at Eide Bailly. Kimberly has more than 25 years of healthcare leadership experience, providing services to acute and specialty hospital and health systems, both for-profit and non-for-profit, critical access hospitals, group provider practices with both single and multi-specialties, rural health clinics and FQHCs, as well as revenue cycle outsource firms. She has experience with consulting, training, business development, project management, revenue cycle leadership, patient financial services, patient access, health information management, HIT selection and conversion and implementation. She conducts revenue cycle improvement projects for the healthcare industry, workflow assessments, planning and execution for process improvement, and performs key performance indicator metrics management. She's a member of the Healthcare Financial Management Association, the American Academy of Professional Coders, and the Medical Group Management Association. So I'll turn it over to you, Kim, to share your presentation.
Great. Thank you, Leslie. Welcome, everyone. Again, this is something that's near and dear to my heart, denials management. I actually like to change that up a little bit, change it from denial management. I'd rather see no denials than managing them. So the title kind of speaks for itself, denial avoidance through process improvement. We all know that we're going to receive those denials, but hopefully you'll be able to take away a couple of hints or pointers to help your facilities try to avoid those denials right off the bat. And I have the pleasure of working at Eide Bailly, CPA and business advisory firm, and our core team, I believe we all feel the same way about those sneaky little denials that end up in our accounts receivable. So with all of that, I will go ahead and get started. And if you have any questions throughout, again, either type them in or let me know. My information, as you saw on that first page, is also there if you have questions after this is over. So kind of putting it together, we've gone through a patient at the center of our revenue cycle, making sure we understand how to manage through the patient expectations, looking at our AR, and now we're looking more into the actual denials and working with those insurance companies. Okay, so before we get started, for those of you who were on the other two presentations, this may be a repeat for you, but I'd like to just give a little bit of information about what I'm talking about when I talk about the revenue cycle and where things can actually come from. So I'll just spend a couple of minutes here because really when we talk about denials, they don't start in the business office. The denials end up being discovered in the business office. And they may start as far upstream as a contract, for example, when we're actually contracting with the carriers. There may be things that have just been not communicated down the stream or down the revenue cycle. From patient access, whether it's scheduling or a financial counseling issue or case management, maybe we didn't get the number of days we needed or it wasn't medically necessary, service documentation, maybe it was medically necessary but it wasn't documented appropriately. And then we find those in the claims editor or in the reconciliation of our billing, and then with contractual EOBs that come back through, explanation of benefits that come back through. So making sure that we've got a good process set up so that when it does come back into our business office, we know how to manage it and get it back to the right people to help us correct that issue, and not just the issue today, but the issue for the future as well. So we'll talk a little bit about that as we go through this presentation. First and foremost, it's very important that the expectation be set. At each level within that pictorial I just showed you, within each level, what is the expected accuracy rate of the data that we're entering? And that accuracy rate, we like to see, I used to say do the 92. That was our little logo around our office, was do the 92. It would be great if we could do the 98. 98% accuracy on the data that comes through. because we're always going to have those back-end insurance companies that still, tend to have different edits in the system than maybe we even knew about. So creating policies that truly support our process. That might take process mapping. That might take us really looking at each process, each step that we go through in the business office to work through a denial. It's the way that, so the denials start upstream, but we get them in the business office. We're going to need to be the champions in the business office to say, hey, I continue to see these denials. How can we create a process and then a policy around how our scheduling department can fix this, or how our registration team can make sure that this doesn't happen again, or even how our clinical teams can help make sure the charges are entered correctly. So not only do we need that policy and that process, but we also need to make sure that we've done a thorough training for our teams and not expect them to understand just through a policy or process, but instead really going back and continually training them. And then outline our path for escalation. So if someone isn't, if we continue to see denials coming through because of data entry error, for example, or medically necessary issue, escalate it to either that department director, or is it someone we need to escalate it to outside of our facilities? So we need to escalate this to the insurance carrier and say, hey, every time we submit this type of claim, you deny it. We get it back on our first submission of requesting a review of that denial. Something's going wrong here. And we'll talk more about that as I go through payer scorecards here in just a few minutes. So insurance billing and follow-up all lead us to finding things that maybe payers are doing incorrectly or things that we're doing incorrectly. And I call that, and it's nothing that I made up, I wish I would have made this up, but dispositional receivable management. I'm putting my receivables in like dispositions. And that allows my team to thoroughly understand claims that might be Blue Cross Blue Shield claims, or even a further disposition would be Blue Cross Blue Shield claims that involve radiology, or even farther down the pipe of this dispositional receivable management. Maybe it's Blue Cross Blue Shield radiology claims that are less than $5,000. So you can really hone into specific areas. And maybe it's Blue Cross Blue Shield only a specific group. But it allows that person to become a subject matter expert with that type of receivable that's sitting in your offices. Doing payer scorecards, understanding your payer contracts. Many times when I go into facilities, I ask for payer contracts, and I truly get sort of that glazed over look, like I don't think I've ever seen a payer contract. Now, I'm not saying that every step of the revenue cycle needs to understand the entire contract that we've signed with Blue Cross Blue Shield or Aetna or whoever it might be. Instead, it's really looking at those topics that affect the billing or the revenue cycle. So what do I need at registration? How does that ID number need to look in the system? Does it need a group number or not? What's the timely filing for that claim? Do I have 90 days to get a claim in? Do I have 180 days? If I get that claim in, then how long do I have to get the clean claim in the door? Meaning that if it's denied, how long do I have to get that denial overturned? So really understanding those contracts. Then down to a finer level, understanding how it should have been paid. Because as my cash applications team is posting those EOBs, they should have a general feel for what should have been paid or how that should have looked before they posted that adjustment, for example. All right, and understanding your rights as a provider. And then this is something that's key. Following up with intention, not just claim status. So your intention of a follow-up call or review on the web is that you want to know what the status of that claim is, and you want to know how it's going to be paid. and when you should receive that check. So if they say, oh, it's in processing, I want to know what your process is. How long does it take us to get a claim paid? And start to document that and create a payer file, if you will. So Aetna Group 1, 2, 3, 4 always pays at 45 days, or it always pays at 30 days. So it allows me to utilize my staff appropriately.
And Kim, a few people said they were having trouble hearing. It might just be the connection, but if you could try to speak just a little bit louder.
Sure. Let me see if maybe moving my phone just a little bit closer too, if that's going to help. Well, if you continue to hear Leslie, is that any better?
Yep, it's much louder now.
Okay, good. Then I moved it closer to my mouth. So usually I sound like I'm yelling, so I like to keep it a little bit farther away. All right, well, if it gets worse again, let me know. Okay, so then we move just a little bit deeper into dispositional receivables and the payer scorecard approach. It's a different approach than what we typically see, which is sort of high-low aging. I'm going to look at those dollars that are, over $25,000, and that's going to be my focus right now. And then I'm going to move down the dollar amounts to get through all of my claims. Well, that's an approach that we've used always in the past versus saying all like accounts, so all Blue Cross Blue Shield. When I've got Blue Cross Blue Shield on the phone with me, I'm going to talk about all of the issues that I'm having with Blue Cross Blue Shield as well as any open claims I have. Stratification and then segmenting. So if I'm stratifying my accounts, it's really sort of that same dispositional. It's another way that we could put our accounts into like groups and really find the collectability of those accounts. And it really helps us to show the true story of the accounts receivable so that if I have a group of accounts that I know will not get paid, there's no way based on the information that I have, we performed a service that is not a covered service by that payer, and as a matter of fact, it's a contractual obligation for us. It allows me to truly speak about my accounts receivable in a way that allows me to have my finance team feel really confident about how much we're supposed to be collecting and allows us to plan for the future. Understanding just exactly what's going on also allows you to put work teams together and be able to get through more accounts than we in the past would have been able to by hanging up, calling Blue Cross Blue Shield, hanging up the phone, calling Aetna, hanging up the phone, calling Healthy Net. So it's just a matter of making sure that we can get through as many claims as we can. So this is giving you a little background on how to sort of keep our payers honest, if you will, and giving them that scorecard or that report card. And maybe it's an internal report card, but when we start to find issues or topics that we need to discuss with our representatives at our payers, or the next time we get ready to renegotiate our contract, we have some data that's been built up to show cost, how much it's cost us to do business with that insurance company. And this is the HFMA suggests this type of format where we're showing anything over 60 days old. It shows the best practice and then what your number might look like. And this is fictitious, of course, as far as your number, but best practice is something that we see in the industry, that greater than 60 days should only be 20% for a specific payer, and that might differ depending on your payer mix. So you want to make sure that you've set those best practices based on if you have high volumes of Aetna or United Healthcare or some specific payer, you may see a little bit higher numbers than what we look at for best practice. So keep that in mind. But this allows you to almost gold star your team and give them kudos where they're due versus saying the entire account of United Healthcare is in a mess. So there are some things that we're doing very, very well, and some things that United Healthcare is doing very well. So do this for your top 10 or so payers. So you've got a finger on the pulse of what's happening with those payers. This is probably pretty hard to see, and I believe it's the one that we, no, this one's a little bit different. This is just a KPI indicator that I use for my payers. And it's actually, I have one that I sent along my denial management sort of dashboard. If you guys want to see this close up and personal, let me know, and I'm happy to send this one out to you as well. But it's really just those indicators that I'm looking at for a specific payer. So this particular example is Medicare. And my contact at Medicare is Jesse James, which may be why I'm not getting paid. But it's for whatever month it's in. It's the second week of, or I can't even see it myself, maybe third week of 5. It also shows those key performance indicators that are important to me. Now, you can change these. Just because they're important to me doesn't mean that they're important to your facility. Maybe you've got past some issues, so you don't have to keep a top-line key performance indicator, but always go back and monitor. So in other words, percentage of AR days greater than 90. Maybe we've actually gotten this under control and I no longer need to track that. There's no need to then continue to keep that on my dashboard. Keep those things that are important to you right now in week 3 of 5, December 2009. I think that's blind as a bat. Keep those at the top of your daily reviews, weekly reviews, monthly reviews. And as you can see, I've listed this out by all of the weeks that we might have in that month. So there happens to be 5. So the first 3 are filled in. It allows me to see very clearly today what's happening with this specific payer called Medicare, or this specific payer called United Healthcare, or whatever it might be that's maybe your challenge. And I mentioned before doing your top 10. Well, top 10, what does that mean? Top 10 could be top 10 in volume, number of patients that come in the door. It could be top 10, meaning the percentage of AR that's outstanding. It could be top 10 based on the number of service dollars that we recoup. So that top 10 is going to be your top 10, what's important to you. And maybe there's a straggler out there that you're wanting to build more business with this particular payer, because you know that the employers in your area are switching to this payer. You want to make sure that you're monitoring them. Move them up to your top 10. It's okay. It's a very fluid process. It's not something you have to set in stone and only ever review those top 10 payers, or only ever review these few key performance indicators. Okay? So keep that in mind, and I like to make sure I mention that, because what happens is we've from time to time get focused on these few things, and they start to improve, and we stay focused on those, while other things around are falling down a little bit. So keep that in mind. And then the dispositional component I'd like to talk about a little bit, where we have submitted claims. That's important to me. I want to know how many claims I've submitted, how many I got to close without ever touching them. So really kind of pay attention to what you're monitoring within your facilities. And we'll talk a little more about this as we go through. This will just be something you can go back and reference. And again, if you want it in a clear format, let me know. All right. Okay, so how do we ensure that we're getting paid? Well, I used to be under the thought that our finance department needed to be able to create a model that said for United Healthcare, we get 20% discount. So we're writing off 20%, so everything else should be paid at 80%, and they needed to let me know. I've since changed that train of thought. Well, many years ago I changed that train of thought, but that was something that was truly in the back of my mind, that this should be something finance is telling me. Because my system, and many systems out there that you might be using, they don't adjudicate claims for us, so we're not exactly sure. We're not able to add our fee schedules in. So it makes it a little bit difficult to know if we truly got paid what we should have. But really what we need to do is kind of start this upstream a little bit to ensure that we're doing everything we need to do to get that payer to do what they're supposed to do. And that is to make sure that we really trained our insurance verification teams to not just request coverage, but truly list out and, if possible, get in writing exactly what it is that we're anticipating for payment. So we know that we can't always know exactly what codes we're going to be putting on a claim form before we submit them. We all know that. But if we can get as close to that procedure as possible when we're verifying coverage and benefits, it allows us to really know on the back end that, hey, out of this $1,000, we should be getting $500. And of that $500, $400 should come from the insurance company and $100 should come from the patient. We should be able to get down to that sort of granular level when we know what codes we're going to be submitting. So identify the data that the payers are using to determine your fee schedules. I can't tell you how many times we have a contract that says they're going to pay us 80% of charges. And that's what we hear in the business office. What we failed to do was understand that with 80% of charges with certain carve-outs, certain things aren't going to be paid. Certain extra supplies or services that we're rendering during that surgery, those aren't going to be paid. That means I'm not going to make 80%. So we really need to delve in and understand what the payer is using to determine our reimbursement, and then really work with sort of those lower paying carriers. Maybe they're using an algorithm that has nothing to do with current modern healthcare, and they're using something from the 1920s. I'm teasing. It feels like that sometimes. But really try to understand how they calculate percentage of charges or percentage of a fee schedule. Okay? And they're not always like up on sharing that data with us. That's not something that they really want to tell us how they decided what usual and customary was. But if we can push and ask each time, they'll hopefully start to divulge some of that information to us. And so track that through your EOBs as well. And then review your reductions. I think that a reduction is just as damaging as a non-payment to my bottom line. So make sure that you're logging and tracking and really going back to those payers when they've underpaid you or when you feel like they've underpaid you, and challenge them. So that's going to mean that someone's going to need to monitor this, but challenge them on those dollars that they aren't paying you. Those are our dollars that need to stay in our facility, not be left on the table. And then understanding your payers. You know, they're really, and this has been going on for a long time, it's not something that's new, but they have very sophisticated technology, although they want us to believe not. But I believe that there's some pretty sophisticated technology that's out there that they're able to put in certain edits that maybe we don't know about. And so it's really the number of edits that are out there. I can tell you that if I were to sit here and tell you that I can help you to do away with all denials, I would be fibbing. So it's inevitable that you will need to work a denial somewhere in your career if this is what you do. But what we need to do is make sure that we can set up our bill edits as robust as possible, use the data that we have from explanation of benefits from the past, so that's our experiential data. So anything that we've got experience with, let's start to list that, watch it, monitor it, make sure we've got edits in our system that help us to avoid those types of denials, and continually process improve. I can't fix one denial and think that I'm done. Instead, I have to fix that denial and then go back to the source where that denial might have happened. Again, whether it be registration, whether it be clinical departments when charge entry was happening, whether it be coding, maybe they missed a modifier, whether it be case management, whether they didn't get an authorization for continued care. It's not a finger-pointing game. It is really an educational process. So if we keep that in mind as we're going through a denial process, it allows us to improve and avoid denials on the back end. And then making sure that you're really communicating amongst the groups. I like to recommend having a denial management team that's a cross-functional team, so that it's not just including revenue cycle folks. Instead, it's including clinical and clinical documentation improvement folks and coders, and having that team together so we can all talk about what we need to do to better improve. All right. So resolving those discrepancies. Denials and underpayments, I've already mentioned that I feel like they've got a very harmful impact on our bottom line. And so to really understand and educate our team as well as the patient on what's going to happen with their insurance causes us to be able to get through when we do have a denial and get that turned over and back into our pockets instead of leaving it on the table. So make sure that we understand from each contract how we're supposed to verify coverage, what's their appeal process, how do they determine timely filing rules, and does that match what the law in your state is for timely filing? Is it on a fee schedule or a percentage of charges? Are there any special billing requirements? We need to know these things, actually not just in the business office, but we need to know this when the patient is presenting for a service or calling us to schedule a service. So, and really create that payment discrepancy team or denial team so that you can prevent these denials from happening in the future. Since those insurance companies do have the robust claims processing and checking softwares, and so all of those things that we need to do help us to make our way around some of those edits. So we want to make sure that we're already having reductions happening to us that are happening just automatically through what's going on in healthcare today. What we don't need is things that are being reduced because we could have done something differently. So. All right. Tracking your denials and trending them then becomes an important part of process improvement. And I have this question on here. Have you ever asked yourself, how do I submit the same claim and the tactics seem the same to delay or deny my claims? It feels like every day I've got so many denials sitting on my desk, and today it's medical necessity denials, and tomorrow it's technical denials, and so it's a continued process. But being able to track, because I say that, it feels like there are dozens of them. In reality, I may only have a couple, or a small percentage of my AR has been denied. So instead of setting ourselves up sort of to feel that failure, let's set ourselves up to really know what it is that's going on with our accounts receivable. And that's by tracking by payer, by type of denial, and trending that so that I can have conversations with upstream, downstream, keeping everyone motivated to continue through this process. Report overturned denials, not just those that have been denied. And here's why. When I think about an overturned denial, the hair on the back of my neck sort of stands, because it feels to me like it was more of a delay process. I want to know how much it's really costing me to do business with that payer. Because if each time I submit a claim, they deny my claim, even though my contract says they shouldn't have, and I'm able to overturn that claim within the first submission of an appeal, I want to track that. So the next time I come to negotiations, I can say, hey, you cost me in time, you've cost me in money. And so let's talk about what you're going to be paying. And not always can you negotiate an insurance contract. Sometimes it's put in front of you and that's what it is. But at least you and your whoever's doing that negotiation, your leadership team that's doing that negotiation, they know whether they want to enter into this contract based on a lot of different criteria, but one of the criteria being how much does it actually cost me to do business with this payer. So keep that in mind and make sure that you're able to come up with a process that allows you to, sorry, they're calling overhead for people. My apologies for that if you could hear that. Make sure that you have a way to really track and allow you to prevent those denials for the future. And that comes through, I use scorecards a lot. So I had a payer scorecard, now I'm having a denial scorecard, which allows me to track by payer, by reason, by department within the facility, by percentage of revenue that's been submitted, denials as a percentage of my gross revenue, those denials that were overturned, and then payer rejects as a percentage of my agreements that have been processed. So if I have, and this is not necessarily in dollars, this is in the number of agreements that have been processed. So if I have 200 claims that I've submitted to a payer and 3 of them denied and I had to reprocess those, I want to know that percentage, because if it's 3, I might be able to live with it. If it's 50, I might not be able to, because each time I'm submitting a claim, I feel like every other one is ending up back in my office. So make sure that you know those percentages. It helps you to have that conversation with whoever it is that you need to have that conversation with, whether it be your team who's feeling frustrated, your patients who are going, hey, I keep getting these denials. It really intrudes on the relationship of you and your patient when insurance companies deny inappropriately. So this is that dashboard that I believe you guys have in the bigger format that came through as well, where I do use this, and I use it because I want to know the number of claims that were created. And we've kind of talked through this, but creating a dashboard such as this allows you to really have at your fingertips those numbers that help you either to show your team that they're doing a great job, or help to improve in certain areas, to say, hey, here's our opportunities. And it also allows you to have the conversations with your leadership and insurance payer. And what I'd like to point out is just keeping track of those open denials, those things that when they come through, I'm going to give you a little story of myself because I think it helps to sort of drive this home. My daughter broke both her wrists. If you were on the other calls, you already know that, but she broke both of her wrists. She's 16 years old. And I never once worried about whether my insurance company was going to pay. I actually really didn't care. I wanted her fixed and out of pain. So she had bilateral wrist surgery and titanium screws put into her wrist. Well, no one ever talked to me about the dollars or the cents of it all. But I got an EOB in the mail that said, Kim, you owe $22,204. Please pay your provider. And it came from my insurance company. It was in an EOB format. I thought for sure I was going to have a heart attack. But I took a step back and went, okay, no, this isn't denied. I know that they're going to pay. But there were maybe 7 different providers that we had seen along the road. And 4 of those providers took that EOB to heart and put everything to patient responsibility. And so I began then to get those nasty grams in the mail while I was working with my insurance company. And phone calls to my cell phone saying, well, you owe this money, and it's going to be whatever that provider was, might have been $10,000, and I'm like, no, I know I don't owe it. But so now I become a full-time manager of those 7 accounts, or those seven different places that I had to go. on something that I thankfully understand how to talk to my insurance company. So using a denial process allows you to make determinations on whether you're going to automatically transfer that to a patient responsibility, or if you're going to know that an insurance company could make a mistake too and put something to patient responsibility. So there needs to be an investigation process. That's why I keep track of open denials, so that I'm not leaving them open forever. Instead, I'm going, okay, I got the COB. I think they should have been covered by their insurance company. I'm going to leave it as an open denial until I get some type of, either my time passes and it's 15 days from now I haven't heard from the patient, I haven't been able to get any information. Now I might transfer it to patient responsibility. But this truly allows you to track what's outstanding and why things are being denied. Your top 5 reasons that things are being denied. All right, and then making sure that you're appealing those things that should have been paid. Cite ERISA and state laws in your appeal position. Make sure that it really helps to support what you're doing. There's some great products out there that I won't mention here on the call. I'm not sure if I'm supposed to, but that can help you to write some of those pretty tough appeals, so that you can try to get those overturned. Be firm. Make sure that you are communicating. Your front end or financial clearance people are communicating with your back end, or your case management is communicating with your person who's doing that appeal to say, hey, no, I checked with them. Here's who I talked to. Here's the number that they gave me. So, or here's the confirmation number that they gave me. Make sure that there is a great communication process. There is a standing thought that when we don't communicate, things fall through the cracks, right? I'm not making up anything new. So if I don't know that case management should have gotten that authorization because the business office, I didn't know that they got authorizations. I thought financial counseling got them or financial clearance got them. Make sure that the person who's doing your denials understands, or working through your denials, understands who has contributed to this account, so that you can go back and write these appropriately. Request prompt payment for something that insurance payer didn't pay appropriately. Make sure that you send supporting documentation where you can. Request a copy of their fee schedules if you feel like it's an incorrect payment. They're not always willing to just divulge that information, but stand firm. Know your position and know your rights, that you can request how they came up with the fees that they paid you. Having your core teams available, I call it the integrated unbilled receivable management. Anything that is sitting out there unbilled or sitting out there as unpaid, make sure that you've got that core team of people so that communication does happen that we just talked about. Pre-processing teams, patient access, case management or care management, charge capture, revenue integrity team, your HIM and coding department, patient financial services. That should be your team of people that come together regularly to talk about how you can process improve. And do it by service line. What's required by each service that maybe your top 50 services that you perform? What are you seeing happening with those service lines? And then your steps is to identify the reason for the denial first. Understand it. Figure out if it's a true denial or if it's something you need to appeal. Route it automatically to the department that needs to help you fix this problem, versus printing, copying, and putting it in a to-do bucket. I am guilty of this myself in my past, where if I sit it in a bucket to do it later, I don't do it. If I don't have time to do it now, I'll never have time to do it because things would just keep stacking up. Have specific staff members within each department that could have been the stem from that denial, that understand denials and understand the importance of getting them done quickly. And make sure that your team understands the technology or the process that they need to go through to get that claim fixed now and for the future. Create your standard workflows, and either manual or automated, Sometimes we don't have the luxury of having technology that's going to automate us through a system. Instead, make sure that you put in your own tickler file. Maybe it's in your Outlook. Maybe it's in some other type of calendar program that will remind you to go back and check that denial. And then create steps, like a step-by-step, almost manual, if you will, for employees to follow, so that workflow process. And that manual can be something that sits on their desk, or it can be something that's stored on their desktop within their computer to really help them if they forgot one step, that checklist, if you will. And then remembering that you have reimbursement opportunities, that it's really difficult to hold an organization's staff accountable when we know we haven't done everything we can do to collect all of the dollars that are owed to us. So it's easier to have conversations when times get a little tough to say, hey, here's what we have to do, when you know that you've done everything you can to hold that insurance company accountable. It's easier to capture that lost reimbursement that should have been paid than to identify operational inefficiencies. And that's so true. We never want to think it's us, but when we can go back and really peel back that onion, if you will, it allows us to really see those areas of opportunity. And so other areas for opportunity might be looking at your coding department, doing periodic DRG and CPT reviews, remembering that Medicare is not your only payer. So while we focus on Medicare a lot, we need to remember that we need to do those types of reviews for our other payers. Don't assume that your coders are up to date. Make sure that you're doing training, because these are some areas where we find some of those denials happening. 20 to 30% error rates are common when we go in and we do reviews. So those are pretty high percentages where when we can do training, we can do continual process improvement, it helps to drive those numbers down. Your coding should be completed by someone who has that understanding or that education. Keeping track of the changes that are going on in your areas to avoid denials. And then just ongoing audits to make sure that everyone is up to date. Internal quality audits and external audits if you feel like it's something that's needed within your facility. Charge capture, we find a lot of issues, 30 to 40% error rates for charge capture. That just means that we've chosen the wrong charge in the system, which then ends up kicking out being denied, or it doesn't match the authorization that we received. Charges may not be up to date. We could be using charges that are charge codes even that are old and outdated, and so they get onto the claim and then get denied. Make sure that you're looking at your CPT and HCPCS codes on a regular basis and comparing those to what your payers say that they should be paying or covering. Part of your revenue integrity thought process, looking at suspense times and make sure that those are communicated. How long does a department have to get charges into the system to avoid late charges? Have those conversations. Make sure that we can do anything we can to avoid those late charges from coming in. Those will look like denials as well now as we move into the future. We've heard tail signs that payers are going to start only accepting the first claim. And if you have late charges that come through, they're going to be rejecting those. And then how will we manage that on the back end? Making sure your charge master is up to date. This is one area that iBailey does a lot of work in, where we review charge masters that maybe there hasn't been a review in many, many years, and so we've got a lot of outdated charges that unfortunately the nurses are still choosing when they're entering charges, or the departments are still choosing, and that causes us to have denials on the back end. Pricing, because of the pricing transparency that we're seeing, we're recommending that you actually do a review of your pricing. Take a peek. Make sure that even if you're paid under a DRG and those individual line items aren't necessarily as important, make sure that you've got those up to date. Because when we have conversations with our patients, it's important for us to understand where our charges are coming from. more information about pricing. What gets measured, I believe, gets improved. And so as we kind of look through this, clean claims. So clean claims to me are those things that get well paid without me having to touch them. And without having to touch them anywhere through the entire process. That's what I consider a closed without a touch or a clean claim percentage. And these are just a few percentages that I'm putting out here for you. There are many ways we can track and trend denials, and those are represented in some of those denial scorecards. But clean claim rates of 93% of all claims should be what I consider clean. So that includes claims that aren't paid within 45 days, claims that are sent more than one time prior to getting paid, claims that might be held in the clearinghouse for a failure, and then truly denials. Those would be what would make up that 7% of not clean claims. And then classifying denials by reason, code, source, cause, and other distinguishing factors. Track those, measure them, find out how many times you're being denied for something that's not medically necessary, something that didn't get an authorization number, and trace it back, do root cause analysis. If I can't mention one thing enough, it's really going back to the source and making sure that education happens. And the American Medical Association reports that between 1.38% and 5.07% of claims are denied on that first submission. Well, whether they're denied legitimately or whether they're denied because of some discrepancy that's happening either between the two systems, that's a lot of dollars that are still sitting out there. And if we don't have a good system in place, we might be losing those dollars. So let's improve that percentage by making sure that we're tracking